Hi everyone, I think we're going to start because it's right at 12 though. Some people are still coming in. Can everybody hear me? Is it? Okay, good. I thought there was a small enough group that the microphone might not be necessary. My name is Maureen Cunningham. I'm one of the faculty at the Center for Global Health, and it is my pleasure to introduce our speaker today, Dr. Haynes, who came to Colorado from Oregon in 2003 and was the founding president and CEO of the Colorado Health Institute. Upon her retirement in 2010, she joined the faculty here at the University of Colorado Health Sciences Center, Health Sciences Campus in the School of Public Health and the Physician Assistant Training Program. Since 2011, Dr. Haynes has been working in South Africa, in Eastern Cape Province, as a faculty mentor in the newly established Clinical Associate Program at the Walter Sisulu University. And she is, in 2014, she was awarded a Fullbright Scholar Grant to spend 9 months at Nelson Mandela Metropolitan University in Port Elizabeth to continue her faculty development activities. And today she's going to be talking to us about influencing health systems reform in South Africa through health professions curriculum and research transformation.
Thank you. I am going to use the microphone because I have a puny voice. Even though there are not a lot of people here, I think we're being taped anyway. Well, I'm happy to be here. I haven't taught here at the school for probably 3 years now because my time has been pretty much consumed with the global health work I've been doing in South Africa. And since it's a small group, I guess one of the things I would like to do is just find out very quickly who you are. Are you a student, a researcher, a faculty member, a retiree, and what your interest is in global health? And why don't we start up here? Oh, no, I'm sorry. We'll start here.
I'm Kelsey Repine. I'm an intern at the Center for Global Health, and I'm applying to med school, and I would like to incorporate global health in medicine in the future.
Good.
I'm Molly Tricane. You guys probably all got the email from me so that you could be here today. I'm staff at the Center for Global Health.
I'm Roberto Delgado. I'm MD, and currently I'm a fellow at the Center for Global Health.
I'm Noel Metcalf. I'm studying public health.
Good. Okay.
I'm Maureen Cunningham. I'm a pediatrician and an investigator at the Center for Global Health.
I'm an oncologist. I work at the Kim Center in radiation.
Good.
I'm Lynn Doran, retired college nurse and faculty, and work overseas and work at
My name is Randy Johnson. I'm in the PhD in epidemiology program.
Good.
My name is Emily Berry, and I'm the MD for global health.
I'm Alex Corte, and I'm a social work student.
I'm Kaylee Couch. I'm a social worker at Children's Hospital.
Good. And?
I'm Larry Green, I'm a family physician.
I remember you from a long time ago.
When you were first starting to see a child.
Yes.
I'm Heather. I'm a nurse and teacher student.
Hi, I'm Gwen Mitchell. I'm a clinical psychologist and a co-founder and idea of global mental health, and then I'm faculty at DU in international disaster psychology.
Interesting. Share it.
I'm Sharon Lavoie. I'm retired from the profession of design and construction and architecture, and we've done numerous buildings to support education and medical facilities, hospitals, and very interesting period of time. And a classmate of Pam's in high school, Detroit, Michigan.
I'm Molly Jankowski, and I'm a retired teacher, and I'm a friend of Pam's, and I'm interested in hearing about your experience here.
Good.
And I'm Kate Jankowski. I'm a public health social worker, recently out of school. So back to the area, and should be on something in Colorado.
And one more right here.
Susan Meyer. I'm a neonatologist on faculty here, and also editor of Helping Babies Food and Helping Babies Survive materials.
Good. Well, I think it was worth taking a couple minutes to find out who you are so I know my audience a little better. I want to begin by thanking, of course, the U.S. State Department and the U.S. Fullbright Commission for its support of my 9 months in the Eastern Cape of South Africa at Nelson Mandela University. It's always good to thank the people who support you. What I want to do today, and I'll go through it quickly, I thought because this is a policy-oriented talk today, which might be different from some of the presentations you have here, which are much more clinically focused, that I'm going to spend a few minutes talking about the political, economic, and social environment on the African continent first, and then the Republic of South Africa in particular, where I've been doing my work for the past 4 years, and then discuss how this policy environment, economic, social, political, has shaped health policy initiatives in the Republic of South Africa. And then end up with what I was actually doing there on my Fullbright, which is trying to make some inroads into mentoring and faculty development around some of the changes that are taking place in the policy environment in South Africa related to higher education, training of health professionals, and meeting a lot of the unmet needs that currently exist. So I was telling Molly before we started, there are some people who believe Africa is a country. I just want to set us all straight. It's a continent. In fact, it's the second largest landmass in the world and has the second most populous, is the second most populous in the world as well. You can see here, typically when we talk about the African continent, we talk about the Saharan, the north part of Africa, and everything below the Saharan desert is referred to as sub-Saharan Africa. So a little bit about Africa in general. For those of you who aren't students of Africa, the continent, the countries are less familiar with Africa. One of the most important, I believe, historical facts about Africa is that it was colonized a couple times in its history, but at the end of the 19th century, Europeans came in and colonized all of the continent with a couple of exceptions. So today there are 54 sovereign countries in Africa, and mostly they are defined geographically and somewhat politically and from a language perspective by the colonists who colonized that portion. Africa continues to be the world's poorest and most underdeveloped continent. I pulled this directly off the web, and this could be a whole session in itself. Why is it underdeveloped? Why is it so poor? Why is the poverty persistent? It has been reported, and from my experience in South Africa, I would say all of these reasons are valid for why the continent and the countries that comprise Africa continue to be challenged. And by the way, you can take notes if you want. I'm happy to make these slides available to anybody if you want them. Corrupt governments. My husband came with me on my Fullbright, and we certainly experienced the corruption in the government in South Africa, and we know from our reading and experience with colleagues we've met from other countries that corruption is a big issue. Human rights violations continue. I mean, there are glaring examples of this throughout all of the sub-Saharan countries. Failed central planning, and I'm going to talk a bit about that in the context of South Africa. High levels of illiteracy as well. I actually pulled out a couple more statistics that I wanted to share with you that didn't get in my slides. So let me. But this is one of the truly challenging aspects of, particularly in South Africa, is because of the impact of apartheid in South Africa. Black South Africans had a very inferior K-12 education system, had very few access points to higher education. And so the whole pipeline from kindergarten through higher ed has been extremely compromised, and therefore a lot of the work I've been doing is at the higher end side of the educational system. But very high levels of illiteracy, goes on and on. And guerrilla warfare, the United Nations actually ranked 25 nations in the bottom of development, and or 25 of them were African countries. It's a very young continent. Population, 50% is 19 years or younger, which is unheard of when we think of our own country and Western Europe, as we are aging so rapidly, and very high rates of poverty, as you can see here. South Africa in particular, which my husband and I got to know pretty intimately. I do want to stop for a moment and say, before I did my Fullbright, I spent 3 years in the Eastern Cape of South Africa at a different university. Actually, the only black medical school in the Eastern Cape, very rural and very high poverty, and I'll give you some statistics on that in a minute. But some of you are quite young. You may not remember the struggles around apartheid. But the National Party, which was if you will, a partnership between the Dutch and the English, the Afrikaans speakers and the English, set up the apartheid government. Segregation existed prior to apartheid, but what happened under the apartheid government was it was institutionalized. And so that black Africans were relocated to what are known as homelands or Bantustans. And you can see here the data from when the apartheid government was in power, around the disproportionate numbers of white in the population and the fact that they controlled all the institutions of the South African government. The whites were at the time and continue to be what our experience has been, quite affluent, although there is a white middle class that has been struggling since the end of apartheid because of some changes in governmental policies around trying to equalize income and access to education. Again, the black population has the lowest standards on income, education, housing, and life expectancy. The most recent data on life expectancy, women at about 60 years of age and men about 57. So when we think about that in the context of our own country, it's rather shocking to think that there are still countries and regions where life expectancy is so truncated. So apartheid officially ended in 1994. So if one thinks about it in a historic context, with the election of Nelson Mandela as the first president representing the African National Congress, we now call it the ANC. I mean, everybody knows the ANC, and there's a lot of growing dissatisfaction with the ANC, although the President Zuma, was just reelected to a second term. I think the fear is that the ANC is a known quantity, and other parties that are trying to get recognized, one that's supposed to be a rainbow party, black and white. I think the majority of the population, which is black, are very weary of electing other than a candidate from the African National Congress, in spite of a lot of the concerns about corruption and lack of sufficient change. It's a parliamentary government. There are 9 provinces, 11 languages. Afrikaans is spoken. It's probably the native language of most whites, although even English-speaking whites, I think in their education, have learned Afrikaans. Afrikaans is also spoken by the colored population, and this is somewhat of an artifact too, because in our own country, many, many years ago, decades ago, we talked about colored people. We don't use that term anymore, but it's an official term of the Census Bureau in South Africa. So colored people are folks of mixed race. So you have Afrikaans, you have white. I mean, the primary native languages are isiXhosa and Zulu, and in the Eastern Cape, it's primarily isiXhosa. So there has been a resurgence of interest among the rising black middle class, particularly in the Eastern Cape, to start publishing in Xhosa and to try to balance out the historical legacy of the Xhosa-speaking people, which in and of itself is very interesting. So the current racial categories in South Africa are white, black, Indian, colored, and Asian just appeared because there's a growing Asian population in South Africa. As you can see here, black Africans constitute almost 80% of the population, and yet have been disenfranchised for decades. And what else? I'm going to leave it at that. Okay, so here are the 9 provinces in South Africa, and if you see the Eastern Cape there, that is where I have been spending my time over the last 4.5 years. And the Eastern Cape is the second poorest province in South Africa, and it is mostly rural, and it is largely black African. As I said, the one medical school there is, so part of the reason that the Eastern Cape is so heavily concentrated black African is because it was a former homeland under apartheid. So it's where blacks were relocated. Here's another map that kind of drills down a bit into the Eastern Cape. And if you see up here, it says Mthatha. That's where I've spent most of my time, actually, in South Africa. That's where Walter Sisulu University is. That's where I worked with the, what we would call physician assistant training program. It's a brand new health profession in South Africa, and it was just coming up when I started working there. So I was doing a lot of faculty development in Mthatha. And down here in Port Elizabeth is where I did my Fullbright. It's quite interesting. The Eastern Cape, really down at Port Elizabeth and south, before the provinces were reconstituted after the end of apartheid, Port Elizabeth was in the Western Cape province. So it has a very different kind of profile, a very different feel. It feels white to me, I mean, when I first went there, as opposed to the northern part where the Transkei and the Ciskei homelands were located. So now I want to switch gears a little bit and talk about the National Health Insurance Scheme that has been fairly recently introduced in South Africa. Actually, the first green paper, they call it a green paper, which is a new term for me. I'm used to white papers. Maybe Dr. Greenwood knows. Anyway, it laid out the framework for a national health insurance scheme, and it has extremely aspirational goals. Is how I would refer to them, and it followed on the heels. Remember, again, we're talking about 1994 was independence, apartheid ended, Nelson Mandela was elected, and with this parliamentary form of government, there's a president and a very strong cabinet of ministers. And so there was increasing and intense efforts to sort of redesign policy around the end of apartheid, and a incredible constitution was developed. Some people have referred to the South African Constitution as the most enlightened constitution in the world. They were one of the first countries to recognize gay marriage. And I only bring that up because it was, it's an example of how enlightened they were as they transitioned from apartheid to democracy, and how many countries, including ours, have lagged quite far behind in some of the human rights efforts that were tackled in the Constitution. Section 27 of the South African Constitution established the right of every individual in South Africa to have access to health care, and that access should be unencumbered by the ability to pay, or and so when you look at sort of the policy development from the 2003 National Health Act, which established the framework for the National Health Insurance Scheme, it's very enlightened. And I'm going to talk a little bit about it. I mean, I think many of us in this room are still aspiring to our own healthcare system, embracing some of the concepts and guarantees for access to health care. The problem is, and being a student of health policy for more years than I would like to admit, the difference between a policy framework and the implementation of policy can be quite vast. There can be quite a gap. And one of the things I was struck by when I first started working in South Africa is the eloquent way they described how they wanted everyone to have access to health care. One of the dimensions I've experienced now over the last 4 years is they are very far from realizing the goals. And that is for a number of reasons, one of which I already mentioned, graft, corruption in the government, people being appointed to ministerial positions who really have no background in health policy. So lots of reasons, but let's talk a little bit about what the policy imperatives that undergird the National Health Insurance Scheme. By the way, I also want to tell you, this is a very humble, in my opinion. I can't imagine a policymaker in this country enacting legislation and say it's going to take 14 years to enact this legislation. Mostly because we're not honest. I mean, think about the Affordable Care Act and how, the minute it became law, it was being criticized for the way it was being implemented. And so, the disjuncture between policy making and policy implementation can be quite broad and vast. If anybody wants to interrupt me with a question or a comment, please feel free to do so. I forgot to say that. But, so here's, and I think, Larry, you would appreciate the strong emphasis on primary care they have there. Partly because there is such a shortage of medical doctors in South Africa. It's another reason that the clinical associate profession was established in 2010, was to try to fill the gap of part of it is lack of not enough medical schools, not enough output of medical doctors. Part of it is actually the flight of medical professionals from South Africa. Some left when apartheid ended, what we would call white flight of doctors. But it's also true that a lot of black African doctors leave once they get their degrees also, because the system is so inadequately funded. And they know that if they go, a lot go to Australia, England, some to the United States. Of course, the United States, it's more difficult because a medical degree in South Africa doesn't equate to a medical degree in the United States. So there's, but in any event, a tremendous shortage of doctors. About 80% of the public healthcare system in South Africa is delivered by nurses. So nurses play a tremendous role in delivering primary health care to the population. So they wanted to, from a policy perspective, build on this primary care base in thinking about how to transform the healthcare system to make it more equitable, to try to equalize the funding streams and bring together the public and private sectors delivering healthcare. There's so many parallels in this country that almost everything I'm going to talk about, I think we could find a parallel here. It's more extreme there, and but some of the challenges which we'll be talking about exist in both of our healthcare systems. So we are finally coming in the U.S. in the 21st century to realize that you have to have a strong primary healthcare base to bring people into the system, to get them triaged appropriately to specialists if that's what they need. And for the social workers in the room, you already know this. It's not always about medical care. So one of the really, again, strong tenets of the transformed primary healthcare system is interprofessional team-based care that's competency-based. So if a person has a social problem, they don't need to see a specialist. If a person needs a lot of prevention and education around managing their chronic disease, again, nurses in most cases are much more well-trained in their competencies, are amenable to health education and monitoring of chronic disease. The other, and this gets to the underfunding of the public healthcare system, is a tremendous emphasis on strengthening the healthcare system itself, and that is in management and human resource development. And this is where I would say my interest grew after working at Walter Sisulu University in understanding that to train competent health managers and healthcare professionals, it does start at the university level. And I felt at the time this was where I could make the greatest contribution. The problems are so endemic and deep-seated that I sometimes think starting at K-12 education or somewhere else in the system. But at every level within the system, there's room for those of you who are interested in global health work to make a contribution. Also, real strong emphasis on community embeddedness and making health systems, primary care systems, very embedded in the community. So training new cadres of community health workers, which we also do here because we recognize how important they are. So very quickly, re-engineering of the primary healthcare system, a comprehensive primary care package, and that is provided through a number of different facilities, particularly in the rural areas. One of the difficult concepts for me to understand when I first started working in Umtata is they consider district hospitals to be primary care sites. And when I hear hospital, I don't think primary care. But because of the structure of the healthcare system as it was and as it is evolving, there are community clinics that are run by nurses, community health centers run by nurses, with some consultation from doctors. But the district hospital is where doctors provide most of the care. That is anything beyond very basic level primary care. But a new emphasis on school-based healthcare and community outreach. This is a schematic describing what I just said, showing you one of the really important tenets of health reform in South Africa that I think has really fallen quite short is the devolution of responsibility from the national government to the provincial government, to the district health care, and then to the community. There's not enough human resource development. Many of the nurses that are providing care in primary healthcare clinics are minimally trained nurses. And so there's a lot of need for strengthening the capacity of the workforce. And so when you devolve responsibility, and in many cases, the money goes down to the district, from the provincial level to the district health level. And if you have health managers who have never been trained to be health managers, part of the problem is the money isn't spent wisely. They run out of drugs. The facilities are falling apart. I mean, it's the litany of problems goes on and on. So a lot of the work that needs to take place in actualizing this kind of model is strengthening the capacity of the providers and the community to provide these services. The school-based health services are entirely run by nurses, and interestingly, by retired nurses. Because that's where they could find a workforce, given the demands on the community clinics for nursing and so forth. So lots of issues there. So I'm going to switch now, drill down a little bit more to Nelson Mandela Metropolitan University, which is where I did my Fullbright. And Nelson Mandela does not have a medical school. It has a faculty of health sciences with 12 different programs, and those are contained in 4 schools. Clinical care sciences, which is nursing, radiography, what else is in there? Medical technology, clinical services, short of doctor education, behavioral health. Very strong school there, social work, psychology, clinical psychology, environmental health, which is a little bit of a stretch, but that's where it is. Medicinal sciences is largely pharmacy, and lifestyle sciences, which which I always thought was an anomaly with all the needs they have to have lifestyle sciences. So you have, physiotherapy, very important profession, but some of the, what do you call it? People who help people train. Personal trainer kind of things. But as I got to know the faculty there, because one of the things I did was actually write a grant for the faculty, I came to understand why it was important. Chronic disease, just like in this country and many countries, is rising quickly as opposed to infectious disease as the leading causes of death. And obesity is a major problem. And nutrition. Nutritionists, dietitians are also in lifestyle sciences. So the job the project that I set forth to do was to work across these faculties and look at ways, because the dean was very interested in doing interdisciplinary or interprofessional training for core coursework, which then got translated into interprofessional research projects. So, but I want to stop at this moment and just show you how NMMU, which it took me about 5 months to be able to say that quickly, NMMU, how they conceptualized the primary care model. They went through a very extensive planning process among the faculty. It lasted about 18 months. Sort of unbundling these terms about social accountability, community engagement, systems understanding and teaching and learning, community-based. What does competency mean when you're training clinicians? What is excellence in educational practice, and how do you promote access and diversity? Remember, I said a few minutes ago how Black South Africans had very little access to higher education under apartheid. So lots of issues around people who needed a lot of remedial work to come into the university and succeed. So how could the university itself help to facilitate that kind of remedial education so that they were training more? So I'll just, you can look at this. I'm going to go through it very quickly. A large emphasis on integrating theory and practice. A lot of the issues I'm talking about here were also issues at Walter Sisulu University in Umtata. Clinical Associates, this brand new program, when they first started it, they spent 1 month on campus and the rest of the year in a district hospital, being mentored and using problem-based learning. They came to learn after a few years, and we did some early evaluation work for them, particularly students feeling that a month on campus was not enough time to learn anatomy and physiology and pharmacology. And so they've modified their curriculum. They're spending 2.5 months on campus, which is not a whole lot better. But lots of things happening. But this idea of early exposure to clinical practice is a very strong tenet of the way Nelson Mandela, the biopsychosocial model, again, with a focus on generalism, team-based care, and then person-centered approach. A lot of emphasis on how do we do a better job of being where patients are when they come to see us. So I'm not going to spend a lot of time on this. Like I said, if you wanted to have a set of these slides, I think it's pretty self-explanatory, but the reason I put these slides up here is to show you the thought and the work that has gone into recurriculation at Nelson Mandela to try to be more responsive to the needs of the community and the population. I think this one is worth mentioning. Nelson Mandela has a scheme. They've actually hired someone to help them develop multiple entry points and exit points into the health professions. So that, and their goal is to have a medical school by 2020. That got sort of tied up in politics because Walter Sisulu wants to be the only medical school in the Eastern Cape. So that's kind of working itself through the political process. But if you thought you wanted to be a doctor and you came in and you had the appropriate remedial coursework, but you find yourself really enjoying social work or clinical psychology, you could branch off. In theory, you can do that in this country too, but typically when we accept students into a program, we accept them into medicine, nursing, social work, psychology. So the idea here was to be a bit more fluid about how people could enter and exit the health professions. Now, so what are some of the challenges to this very quick overview I've given you of health reform? Well, when the Green Paper was first published in 2011, there were a number of seminars and gatherings of individuals from various vantage points, maybe medicine, maybe hospital providers, etc., politicians. There's not a lot of consensus that the problem is that we have to redesign the whole system. A lot of people believe if you just put more money into the system, it would make things better. And there's a part of me that's, can certainly sympathize with that point of view. The public health care system is so underfunded in South Africa. I forgot to mention, 80% of the population's in the public health care system, 20% in the private. 80% of the doctors serve the private system, and 20% serve the public. So it's the exact, need and access do not line up at all. And so part of the National Health Insurance Scheme that I didn't spend any time on because I wanted to focus on the primary care piece of it is to bring together the public and private system, to get private doctors to see public patients. Now, we know how well that works in this country, right? How well does that work? How well do doctors embrace Medicaid patients or uninsured patients? Well, they have the same problem there, only it's even worse because at least in this country we have funding streams to support uninsured patients. We have a Medicaid program that I don't even know what it pays now relative to, it used to be 20 cents on the dollar or something. I don't know what it is now. I think the pot has been sweetened through the Affordable Care Act. But in any event, so again, the aspirational versus the reality. I don't see in my lifetime the public and private sectors coming together in South Africa because the public sector it's actually, the problems are exacerbating. They're getting worse in terms of resources. Because now the population has an expectation that they have a right to health care, they have a right to getting, if they need a specialist, they have a right to that. Specialist care, again, like in this country for public patients, is woefully inaccessible. There has been a major stagnation in the production of healthcare workers, declines in essential categories, particularly in nursing, and as I already said, attrition and migration of health professionals out of the country. So these are all challenges to setting up the ideal healthcare system when you don't have a workforce and you don't have resources to support it. I think management cannot be underestimated, the importance of good health managers, clinic managers, hospital administrators. In many of the hospitals we visited in the northern Eastern Cape, in Mthatha, affiliated with Walter Sisulu University, they would go through administrators, like in and out the door, because administrators would get frustrated because they didn't have the resources to keep the hospital running. Management is very important. Training good health managers, very important. poor working conditions, and of course maldistribution, which is the same thing we have in this country between urban and rural areas. So now I'm going to skip ahead to, what did I do? Sometimes I ask myself that question also. This is the second Fullbright I've had in my career. My first one was in Poland, where I was at the Oregon Health Sciences University in the School of Public Health and Preventive Medicine, and we had a partnership with a health district in Azerbaijan. And so I know the limitations. Well, that was that, but my time in Poland, I'm skipping ahead here, I was only there for one semester, and it took me almost the whole semester to get embedded in the faculty, and then I had to leave. And that's part of the reason I wanted to do a longer stay in South Africa. But what I said I was going to do in my proposal that was so brilliant, they funded it, and what I actually did was not very different, but significantly different, okay? In that I had met the dean of the Faculty of Health Sciences at Nelson Mandela when I was working at Walter Sisulu, and he was a new dean, and he told me that he really wanted to push the faculty toward interprofessional education and research. And we talked, and I told him about my own background and my interest in that and work I had done in that area, both in Oregon and at University of Wisconsin when I was there. So he said, well, I would love for you to come to Nelson Mandela, and let's try and make that happen. And so that's the background. When I got there, the dean had just consolidated the faculty into these 4 schools that I told you about in 12 departments. Made people responsible for bringing those schools along, and not only at Nelson Mandela, but at universities throughout South Africa, a tremendous interest in recurriculation, or changing the curriculum to be more relevant to the needs of the population. So, and again, in response to the inequities in the access to higher education and health professions training. So this was the impetus. This is sort of the background for which I thought, well, I believed I could make a contribution. This is how I would describe in a nutshell what happened when I got there. There was a lot of planning that went on at the university in the faculty. There were faculty-wide meetings. There were, how are we going to make this happen? How are we going to change our curriculum? So 2 of the things that I actually ended up accomplishing while I was there during my time, and again, it took me 3 or 4 months to get to know the faculty, to build some trusting relationships with people, to, you can't, if we had a session on how to do global health work, and I'm sure you've heard this from many speakers before me, you don't go into a new culture and a new situation and think you have all the answers. In spite of the fact that I had a blueprint for what I wanted to accomplish, I knew that I had to spend a lot of time listening and understanding how people felt about this recurriculation process. How do they really feel about interdisciplinary curriculum and research? I did design and deliver a interprofessional research. So one of the things, let me step back a minute. The curriculum redesign was so daunting to the faculty because they had just gone through other curriculum redesign to meet the professional standards that were imposed on them by licensing boards and bureaus and governmental bureaucracy, about competencies, about length of training, required courses, etc. And in the interdisciplinary work I did at University of Wisconsin in 19 80, 81, it was the same problem. People were saying, we don't, we're on different calendars, we're on different schedules. We have required courses for our medical students and nursing students and social work. And we can't, how do you expect us to fit this additional, this new lens, this new way of thinking about how we train health professionals? So I think that's true. I mean, so I thought, well, what would happen if instead of talking about how we're going to redesign the curriculum, we talked about ways to do collaborative research together? Because nurses and social workers and doctors and physiotherapists, they're seeing the same patients, and they do have a unique lens and a unique set of competencies. So if you wanted to do a research project around a population, how wouldn't it be interesting to do that from an interprofessional perspective? And so I sort of shifted the focus to interprofessional research. I still couldn't get people terribly interested because, they came. I had somebody from each school. But they still couldn't see how it fit into their own research agenda as a nurse or a particular health professional. So the seminar series didn't go so well, but voila. 3 months before I left, the dean asked me to write a grant proposal for him, which I'm pretty darn good at writing grant proposals. I think it has been the salvation of my career. And the Department of Higher Education and Training told the dean they would give him 10 million rand for 1 year to start this process going. So I wrote the grant proposal in a little over a week because that's when it was due, and we got funded. And in that grant proposal, I set aside 800,000 rand for an interdisciplinary research unit, and I'll talk about that in a minute. But that's what was needed to kickstart people thinking, yeah, it's not that they didn't want to, it's not that they didn't embrace interdisciplinary focus. The problem is there are just too many demands. And these are for that applied there, but I'm sure they would apply here too, using different words or different concepts. The Health Professions Council of South Africa is very prescriptive. That's where the health professions boards are, about what courses each health profession has to take and what is required for licensure. So they do profession-specific core competencies, but the idea of looking at where core competencies overlap, not a part of the agenda. I've already said competing demands on curriculum development, competing teaching and postgraduate responsibilities. Some of the faculty were sponsoring 15 doctoral students and another 15 master's students. Well, you can't, I know from experience, you can't do justice to your students if you have 30 students you're supervising. And they have a very different graduate education system. It's very British. So doctoral students don't take any coursework. They find a supervisor, and that supervisor is supposed to train them in research methods and how to do research, and which wasn't happening either. So I really found my niche, if you will, in this whole area of student mentoring, graduate student mentoring. And finally, the incentives that reward individual research projects are established by the National Research Foundation. We don't have a comparable body here that I can think of. I mean, there are, here, we publish in peer-reviewed journals. If we get an NIH grant, we are really on top of the world. You know what I mean? So our reward system around research and publishing is slightly different, but it's still focused on who am I as a researcher, and what does my research portfolio look like? And we try to distinguish ourselves. It's probably one of the reasons I never really fully embraced higher education as my career, and why I came to do CHI, because I was much more interested in interdisciplinary and much more interested in influencing policy with research, not my own. We didn't have PIs at Colorado Health Institute. But anyway, so these are sort of the barriers that we faced and continue to face. And also, finally, the status quo is a very powerful. I have already talked about the resources. This is how I want to leave my talk. I've truncated it. I do want to say that the grant provided a small grants funding program for faculty across the 4 schools and 12 departments to actually design and start doing pilot projects around interdisciplinary work. And the woman who is in charge of that, we're in pretty constant contact, is so excited because she said that was all we needed. We needed an incentive to get people to start working together, and now they're on fire. You know, they're doing the seed. They've got the seed projects, the pilots. They're writing fuller grant proposals. So you know, I guess the message there is you can't do it out of goodwill alone or commitment alone. So these are the questions I think about when I think about my own career as a faculty member at several universities. And so I want to leave you with this, and we have 4 minutes to talk about it. To what extent do we sensitize and challenge ourselves and our students to consider the broader health policy environment in which they will practice? To the broader socioeconomic political environment in which community members and patients live, work, raise families, and grow old? And secondarily, to what extent do we consider those factors when mentoring students in research and encouraging a more holistic look at what contributes to ill health, disease, and premature morbidity and mortality? So I'm going to leave it with that. Comments? Questions? Yes?
Thank you. Covered a lot of territory.
I know.
I was privileged to work in South Africa twice. Once before the academic boycott was over, and as a part-time student, but before the elections in '94 and then once after. And yeah, I think critical context is to realize this is the country where the first heart transplant was done.
Yes.
This is a country that has been simply devastated by HIV. This is a country that is filled with some of the unbelievably most beautiful people on the planet, living on some of the greatest real estate on the planet. I mean, it's just spectacular.
Oh, I meant to put that up.
And another, I think, key context for this panel is the United States was 20 years into perfecting its democracy in 1796. 1796, and that's where they are. And I think it's okay to cut them a little slack about stuff. But I was so taken with what you said about those small grants. And your last question is about thinking about what it is, how do you work in these settings? And I think that's the take-home message. We should all be thinking about what $1,000. What's a rand worth now?
Oh, it's worth $1. Well, a rand is worth 10 cents.
So 10 rands to $1.
Right.
So $1,000 is a 10,000 rand grant.
And 10 million rand sounded like so much money, but it's $1 million. And we were able to spread that out across.
It's amazing what these people can do with something like that.
Mm-hmm.
And they just deserve it. And remember, this is the country that left the United States being the only developed country in the world without universal health coverage. There were two of them, South Africa and the U.S. Now there's just the U.S. And that aspiration, the contrast between the aspiration and competence and capacity, competence and capacity, that's so painful to live in.
Yeah, it's very painful.
And you come back home, and another take-home message for me is the indictment and the continued struggle and striving for such worthy goals. And most of us here at the Academic Health Center just complain that they're not being any money, which is just bad.
Mm-hmm. I couldn't agree more. Yeah. You know, I did leave out some of the statistics that I wanted to throw in, but your point about being devastated by HIV/AIDS, and infant and maternal and early childhood mortality in South Africa, especially in the Eastern Cape, is there shouldn't be those kinds of under 5 child mortality. In the Eastern Cape is 104 per 1,000 live births. Maternal mortality, 400 per 100,000. And infant mortality, 53 per 1,000. So these are statistics that are just hard to believe. I mean, South Africa is one of the richest African countries on the continent. But the income, we think we have income disparity in this country. Well, we do. I'm not minimizing it. But the income disparity in South Africa is just hard to fathom because there's so much wealth and so much poverty at the same time.
Well, forgive me for speaking up again here, but so I've kept in contact with people that I worked with there 20, 25 years ago. A guy named Bogisho, who was the first person in his village out in the Transvaal to go to medical school. He spent his first year in medical school understanding the city. Where do you go to do laundry? But he survived. Well trained. He grew up to be a general physician. Mm-hmm. He works in one of the district hospitals out in Missouri. We usually talk Christmas Eve. And so he calls, and he has 231 patients in the hospital. He's the only guy. And many of those are laboring women. Uh-huh. And, we read about preeclampsia. He had 3 eclamptic patients right there. Women that were seizing in the hospital. They were trying to get delivered. And I bring this up to point out that he's still there.
Mm-hmm. Yeah. And there are people on the faculty at Walter Sisulu who are not even Black African faculty. One woman I know from Sri Lanka who's been on the faculty there for 30 years. And they have so many challenges in Mthatha, and the health district in which the medical school is located has some of the highest infant mortality AIDS rates in the country. And people do stay. I mean, the commitment of people is truly amazing. And I would like to echo what you said about some of the most beautiful people that I met there. So it's a very complex country, and it's very humbling to spend time. And
it makes our Congress look like a piece of cake.
Well, thank you all for coming. Okay.
Thank you, Pam. We will post the slides on the Center for Global Health Lecture Series page, and Pam's talk will also be available